So I can see our attendees are populating, and I'd like to welcome everyone to today's event, Ketamine-assisted therapy in psychiatry, spiritual group and meditative frameworks potentiating clinical benefits. Today's event is co-sponsored by the USC Institute for Integrative Health and Wellness and the USC Center for Mindfulness Science. I'd like to take a few moments to give some context and background about the communities who have come together to help put together today's event with our distinguished speakers, Scott Shannon and Elias Dakwar. The USC Institute for Integrative Health and Wellness mission is to promote the health and healing of individuals, families, and communities we serve through the advancement of the practice of integrative health, the science upon which it is based, and the education of healthcare practitioners and the USC community. Vision is to transform healthcare by establishing a collaborative, holistic paradigm that promotes health and healing and integrates all aspects of human life: physical, emotional, mental, spiritual, cultural, social, and environmental. And the USC Center for Mindfulness Science mission is to cultivate individual and societal awareness, well-being, and transformation of suffering through scientific understanding of the impact of mindfulness and related practices on human consciousness and health. And our vision is a kinder, wiser, more compassionate world arrived at by integrating the scientific understanding of consciousness and compassion, thus promoting human transformation and societal flourishing. I'd like to read through this land acknowledgement. The Institute for Integrative Health and Wellness, Center for Mindfulness Science at the University of Southern California, and Children's Hospital of Los Angeles acknowledges and honors our presence on the traditional, ancestral, and unceded territory of the Gabrielino Tongva peoples. We recognize that these peoples were forcibly removed from their homelands, and we take this opportunity to acknowledge the generations that have gone before, as well as the present-day Gabrielino Tongva people. With humility, we recognize and respect all indigenous peoples, their histories, and their ties to the land. We also recognize the Chumash, Tataviam, Serrano, Cahuilla, Juanino, and Luciano people for the land that USC occupies around Southern California. We pay respects to their past and their present. Let this acknowledgement serve as an ongoing reminder of the original inhabitants where we reside. And for those who are attending with an interest in CME credit, the activity code is 45STAT. You can actually put your mobile phone camera on this little QR code, and it will bring you to the page to register in order to be able to claim the credits. And it's a little instruction if you don't have the EEDZ mobile app that will help with this whole process. If you have difficulty with this, contact the organizers and we can help you after the fact. This is a little bit of honoring the communities supporting the USC Institute for Integrative Health and Wellness, Executive Steering Committee and staff, as well as the Center for Mindfulness Science. And I'll start with a really brief introduction of myself. I am Rael Khan. I'm a psychiatrist and neuroscientist here at USC and the founder and director of the Center for Mindfulness Science. And today's event is near and dear to my heart, and I'm very happy to have Dr. Shannon and Dr. Dakwar speak for us on this topic of ketamine-assisted therapy in psychiatry, insights into the group, spiritual, and meditative frameworks that can really potentiate psychedelic therapy benefits. And I'll just mention that land acknowledgement that I just read really speaks especially true to me in regards to this presentation. While we're not speaking about the psychedelic plant medicines that are native to the land we inhabit here in the Los Angeles area, but instead this, pilot initial psychedelic that the modern West has deemed appropriate to legalize for clinical use and widespread availability now, which is ketamine, a very fascinating compound. The indigenous peoples of North America and the world over have been using psychedelic-assisted therapies as integral to healing practices for millennia. So I think it's really especially appropriate that we acknowledge our indigenous brothers and sisters and their cultures and the traditions that actually kept these practices alive long enough for us in the modern Western world to now be rediscovering their clinical efficacy and making a contribution to the modern practice of psychiatry. This is just a brief preview of some of the next events we'll be offering through the IIHW with a symposium on trauma-informed care and a speaker that the Center for Mindfulness Science will be having in the next month or so, exact dates still to be determined, with Antoine Lutz on the neurophenomenology of mindfulness and clinical applications. And the part 3 of our psychedelic-assisted therapy mini-series, which will be in January on psilocybin-assisted psychotherapy. Okay. Scott Shannon has been a student of consciousness since his honors thesis on that topic at the University of Arizona in the 1970s. Following medical school, MDMA, excuse me, I've just lost track of my screen here. Following medical school, MDMA-assisted psychotherapy became part of his practice before this medicine was scheduled. Scott has published 4 books on holistic and integrative mental health and is past president of 2 national medical organizations and currently teaches ketamine-assisted psychotherapy for PRATI, the Psychedelic Research and Training Institute. He serves as a site principal investigator for the phase 3 clinical trial of MDMA-assisted psychotherapy for PTSD and the phase 2B study of LSD in generalized anxiety in Fort Collins. Scott is the founding CEO of the Board of Psychedelic Medicine and Therapies, and I've had the pleasure of working with Scott as one of the principal investigators on the MDMA-assisted psychotherapy trial for PTSD, in my capacity running a sub-study of that, looking at epigenetic change underlying that clinical efficacy. Scott, thank you so much for being with us today, and I'm really looking forward to your presentation.
Well, my pleasure, Rael. And, I want to thank you and the USC Centers for the invitation. And it's kind of interesting because psychedelics and integrative medicine and wellness are 2 threads that have sort of woven through my career and I think are actually like long lost cousins that share the same roots. Happy to be here. And I think one of the things that I want to do today is just be a little bit provocative and go out on some edges and talk about spirituality and group work and how we develop connection, how we bring down barriers, And the fact that these medicines are tools and catalysts for a process that we know well, and that, as you mentioned, go back millennia. So really, what I'd like to explore today is a little bit about what is spirituality, what is healing, why is this so timely right now in terms of this. We seem to be having a psychedelic moment in our society. And as I was just mentioning to you before we went on, is we're still waiting for the results of our referendum in Colorado, and it's slightly ahead to legalize and regulate psilocybin-assisted therapy. So where we've come in the last 20 years with psychedelics has just been an incredible ride, and in some ways a tsunami that we're all riding now. And I think some of it is because there is a spiritual vacuum that people are feeling, and they're hungry for something that can give greater access to the spiritual side of our being. And as I worked in integrative medicine for years, I had gotten away from the psychedelic sort of background I had working with Andy Weil at the University of Arizona in the 70s and 80s. And I felt this vacuum in my life, and it was really a spiritual vacuum, and that I was called back to psychedelics, called back to working with MDMA, ketamine. And actually today we're having our site initiation visit for our 2B study of LSD. So it's in the air right now, and I'm happy to be a part of this wave. And I feel like a surfer who just caught the perfect wave. So happy to be here. I guess that's a Southern California analogy that you can relate to. Well, let me jump in. I've got some slides, and I'll wander around that a bit, and then I'm really looking forward to sharing with you and Elias after we get through the formal part of the presentation. So let's see what we got here. All right. So I really just want to be clear that a lot of this is about perspective. I'm going to use some data as a jumping off point, and a lot of it is speculation. But I think part of trying to understand the draw for this and the nature of the work itself is to be able to put this spirituality piece in context. I've got some disclosures. I've written some books. I'm a PI on a couple different studies, and I'm on an advisory board for Maya Health. So think of a little bit about the tools and the process that we're looking at. We'll get into a little bit on mystical experience, what is healing, talk a little bit about the disruptive innovation that is really just emerging out of all this, spend some time on groups, and then look forward to the panel discussion. So here's just a frame on the different tools that we're working with right now. We have the classic psychedelics, phenethylamines and tryptamines. We have the empathogens like MDMA, MDA, 3-MMC, sort of other categories that are sort of a little harder to get our arms around, ibogaine, 2CB, and then the dissociative agents like ketamine, nitrous oxide, and dextromethorphan. And it's interesting that dextromethorphan is having a moment in psychiatry, a recent new release of medication containing dextromethorphan for treating major depression. And I think its value is that it creates a low-level dissociative state that helps people modulate mood and improve their sense of self. So what I find really useful is not so much to focus on the medications. They're the tools, the catalyst, but really to focus on the psychedelic framework, which is what I call this, internal introspective focus with music and eye shades. We can look at all these different tools, and these things really share very little chemical similarities. They're very different agents. They work through very different mechanisms. But what they share in common is that they're catalysts for changing consciousness. And if we create a therapeutic container with a provider or providers or community that creates safety and support, we can really leverage this catalyst ability. And these are really the epitome of what set and setting can do. And one of the things that grew out of the exploration in the 1960s is to understand that expectation and our sense of what is going to happen or what is possible opens up possibilities of healing and change for people. We'll segue into a little bit, and this is Alex Gray's work. For those of you that aren't familiar with it, it's very inspiring in terms of connecting with our mystical self. The mystical experience has been sort of well defined over time. Probably the core element is this sense of unity, which is really the dropping of barriers, the dropping of separation, the dropping of false differences. And what's interesting is that our culture is really having a moment of the opposite of whatever unity is, which is polarization, othering. And I think this is maybe one of the reasons why ketamine and psychedelics are being called forth in a way now. Other elements of this are ineffability, a sense of sacredness, a transcendence of time, and this noetic quality that we're somehow tapping into or touching some deeper reality that is true and authentic that we don't often have access to. So these are the typical elements of a mystical experience. And we have sort of related psychedelics because of their power to bring forth the mystical experience, but there's many different ways to get there. And one of those ways is with near-death experiences. This may not be something you easily prescribe, because they're not without risk, but the people that get through and experience a near-death experience, they have this sense of serenity, presence of light, a detachment from their body, transcendence of ego and time. But what's even more pervasive and more interesting is this intense feeling of unconditional love that sort of pervades. And what happens when people have a near-death experience is they have this dramatic change in how they view the world. And it is not just being unconscious or not just having a close brush with death, because many people who've had a close brush with death don't have a classic near-death experience. And when there's no near-death experience, when there's no internal reverie that fits this description, they don't have this process connected to it. And interestingly enough, and this is a number of researchers have found this, there's really no connection with religiosity. So people's interest, preference, connection with religion before this experience doesn't drive it. And what happens is that when someone has a near-death experience, they have this dramatic change to their perspective, their worldview, and this creates this ongoing process of post-traumatic growth. And this is very similar to what we see with psychedelic treatment. Particularly, we're seeing it with psilocybin and with MDMA in our trial. And a lot of the parameters of post-traumatic growth that we see with MDMA is that the improvements continue. And with MDMA, we may see 55% of people resolve their PTSD at 2 months. But if you go out 12 months, an even greater number reach that threshold, because this starts a process for them that actually creates this process of ongoing post-traumatic growth, which is one of the interesting things that both of these experiences, near-death experience and psychedelic experience, have. So we know this is probably the most profound and landmark study in psychedelic medicine. Psilocybin can occasion mystical type experiences having substantial and sustained personal meaning and spiritual significance. Roland Griffith's work out of Johns Hopkins in 2006. And just a quick recap, it was a double-blind randomized controlled trial. It wasn't a large study. They used methylphenidate as a control. And 61% of people in the psilocybin group had a complete mystical experience, I think, which says something about the setting they created at Hopkins. But what was even more profound is that this has power. 83% of the people said this was a top 5 event in their life. And the intensity of the mystical experience was predictive, not the power, the intensity of the psychedelic changes, the perceptual changes. once again, these were sustained effects that lasted over time. And if you look at the pattern of effects that happened out of this psilocybin study, decreased hatred, love of others, increased gratitude for life, increased reverence, increased altruism. This sounds like what you get at Sunday school. This sounds like what comes out of a religious process. And I think there's really no observable difference between what happens with a near-death experience, what happens with a mystical experience occasioned by psilocybin, or really a mystical experience that occurs in any way. And these mystical experiences seem to drive the effects with psilocybin. So this is a study from 2018. And you see the difference between the blue and the red lines is where you see the spiritual experience separating from the responders from the non-responders. And the blissful state, the insightfulness, but this experience of unity at the top of the scale, these things seem to drive the difference between responders and non-responders. So one of the ways to think about spiritual healing is that it really is a pervasive, powerful form of healing. And this concept of healing has had interest to me over time. And if we think about healing can occur in different levels and different powers. And, you know, I think one of the things that I've learned as a physician and psychiatrist for 40 years is that there are many different ways to heal people. No one has a monopoly on cures. And that people can vary in how intensely and powerfully they're healed. And I think one of the things that is so attractive about psychedelic medicine is it seems to have a transformative element at its core. Unlike conventional psychiatry, which seems to be managing misery with repeated daily dosing, what we see with psychedelics is this promise of transformation. And the transformation is, I think, talking about this spiritual core. And if we look at these different tiers of healing, and I've got an image here. So in the middle, the bullseye are catalysts to transformation. This is really a new level of order. And I think this is sort of the hallmark of spiritual healing, is that we change our worldview. We see the world in a different way. That changes our behavior. That changes our motivation. That changes our engagement. It changes our relationships. And very often it changes our career. It's an interesting piece of this. But then we can go all the way down to another level, which is looking at suppressive treatments. And I would characterize treating with benzodiazepines and treating with opioids, where they're suppressive therapies that are actually fighting the body's homeostatic mechanism. And those often are harmful because they're actually creating a process that forces the body to respond to it. And then we often respond to the body, and we get in this tug of war with the body's homeostatic wisdom for healing. And it's often damaging. We can do nothing at all, and that may actually be better than some suppressive therapies. Sometimes it's about removing challenges. So improving a diet or getting someone out of an abusive setting or helping somebody to sleep better, that can really help support the very process of life. We can do test and replace, like functional medicine, where we're supporting biology. We can do an ecological manipulation, and I think of family therapy as a sort of a hallmark in here. And then Elias will be talking later about building awareness with meditation. And so this is an agent of change. Meditation in and of itself doesn't transform depression in the moment, but the ongoing process of depression creates a tool of self-awareness that chisels away at some of the false self created over time. So I just thought I'd digress on these tiers of healing. And what really interests me is really going for the bullseye. And I've actually made a decision as a psychiatrist to stop prescribing psychiatric drugs to focus on transformative medicine in the next phase of my career. And that really, this is the goal that I have for people now. And I think that psychiatric medications can be helpful to people, but if we lose sight of transformation, then I think we're doing everyone a disservice. Here are some other catalysts for profound healing. So psychedelics are one. near-death experiences, but world travel and pilgrimage, shamanic journeys, calamity, retreat, spiritual conversion, St. Paul on the road to Damascus. And in the center, pregnancy and parenthood can also be a profound shift in our perspective. So these are catalysts for change that can transform people fundamentally from top to bottom. And this is something that sort of deeply interests me, and understanding how these things can become tools to help support people on a process of transformation. I'll talk a little bit about group therapy, and really it's increasingly my perspective right now that group therapy is the future of psychedelic medicine. And I say that for a couple reasons. Number one, in our deepest cultural roots, this was done in a group process. And I think we will come back to that for a number of reasons. One of the primary reasons is that it builds community, but I think another reason is it actually enhances the power of the treatment. And I say that from anecdote. I don't know that we have comparisons where we can compare psychedelic transformative power in group therapy versus individual therapy, but it's certainly been my observation working with these modalities, and I'm hopeful that we can get research that will support this perspective. So what are some of the benefits of group therapy? Well, I think one of the reasons why it's the future of psychedelic medicine is it brings the cost down. Right now, psychedelic medicine is a treatment of the affluent, and it is very restricted access because of the cost. You want to do psilocybin therapy or you want to do MDMA therapy, you're going to have to sit with a therapist, sometimes two therapists in our MDMA study, for 6 or 8 hours. In the LSD study that we're starting today, our dosing session monitors sit for a minimum of 12 hours with people. So that is a inordinate test of your patience and probably of your gluteal muscles as well. It builds community, enhances support, it normalizes our struggles, reduces stigma, and as I said, I think I'm going to put my money that it enhances efficacy. And I'm not sure the dynamics around that, but I think it's the dynamics that we're a social creature, we're a herd animal, and there's something about being connected with others and going on this journey that gives us power to go further and deeper. And I think we actually have a signal around that in some of the psychedelic research that shows that when people feel safe and secure with their psychotherapist, they have better outcomes. And I think that's beginning to hint at what group therapy can do. So healthcare workers have been particularly at risk over the last couple years, and we're now realizing that rates of burnout are approaching 40 to 60% in our frontline healthcare providers. This nurse in the middle is actually my daughter. This picture was taken while she's working at Harvard Deaconess Hospital in Boston during the surge 2.5 years ago. And I don't know if you remember, but Boston was pretty hard hit, and they were treating people in waiting rooms. She had 6 to 8 patients at a time in makeshift ICUs with no PPE and no contact with loved ones. And it was a very traumatizing experience. And just processing this with her and helping understand her process, I began to realize that we need a modality to treat our caregivers. And the other piece that I've realized over time is that in the mental health field, we're sort of separated this by arm's length or maybe 1 degree of separation. But certainly one of the things that I've learned in my MDMA study is that the vicarious trauma that comes from sitting with people who've had deeply painful and traumatic events is significant. And over time, the vicarious trauma that we have as care providers is often unnoticed, unprocessed, and debilitating. And for that reason, there's really things to do. So this is a study published in January of this year by the Roots to Thrive group out of Vancouver, a similar process to what we've been working with at Wholeness Center. They have a 12-week program, both large and small groups, and they have 3 ketamine sessions built in. And they use a variety of caregivers from the community and creates this really nice community of practice framework. And in their first go round, they had 94 participants. And for example, with PTSD, they had 37 people positive for criteria at the beginning and 5 at discharge. In other words, 86% no longer met criteria at discharge. And they're rolling out another subset of their study in a different part of British Columbia. And we've done a similar study, and we were running this simultaneously. We call it Frontline CAP. We did it with a site in Utah. And it was a 6-week program for frontline healthcare workers and first responders. And what we did is we had 3 medicine sessions, 3 non-medicine sessions. We started with low dose oral, high dose oral, and then IM. Actually, I realized the slide is wrong. So we have oral, IM. And because we started in COVID times, we started with 4 healthcare providers and 2 therapists. And this provides a total of 12 hours of therapy. We funded this through a grant, and we were able to get our cost under $2,000 per person. And the results we saw were just incredible. In monitoring PTSD and depression scales, we saw an effect size of 1 to 2, realizing this is an open label study, but this gets people back to work quickly. And we just really, in fact, one of the emergency room docs that I treated in my group a year ago has now decided he wants to do this work. It's contagious, so there is a contagious element to deal with. So just trying to summarize and pull back around to a picture. Psychedelic medicine is a disruptive innovation in many different ways, and it is going to change our mental health care system. In 10 years, it will not be very recognizable because of the increasingly or less insidious effects of psychedelic medicine over the next 10 years. And one of those pieces is that we're moving from an expert, where it creates separation and pretense from the people we're working with, to equals. We're just simply another human being in the room, helping them on their spiritual, emotional journey in life. And I think the other piece is that because there's really no boundary line between pathology and ill in the psychedelic space, that we're moving towards prevention. Because we can treat the betterment of well people, as Bob Jesse says, we can really move towards prevention. And we have a model that actually improves people's mental health without focusing on pathology. And I think we're moving a place from fear to trust. We're moving a fear of the psyche with antidepressants, antipsychotics, where we're really trying to hide and suppress the psyche, to a place of trust where we recognize the inner healer and the ability of the body to heal itself. And I think this is one of the ways that integrative medicine and psychedelic medicine have this shared core belief. And that part of that model is this model of transformation and not daily medication, as I mentioned before. But just, I think, finally, and in summary, we're really going to move from a model of psychopharmacology, which is in some ways, for example, the chemical imbalance theory, which is really much of what we're doing has been built on, is kind of a pseudoscience. It's kind of an urban myth. We really don't have solid evidence to support it. And I think increasingly nobody gives it great respect, at least in terms of treating depression. And I think with psychedelic medicine, we're moving to a model where we're not going to be focusing on what these things do to neurotransmitters, but how does this open up spiritual connection for people? How does this open up a bond with a deeper unity and connection with self, others, planet, and even our profession? So what and how do we emphasize this movement to spirituality? I think groups do that. I think really understanding the psychedelic framework, and then having a sort of a palette of tools in psychedelic medicine that we can use as catalysts within this container, this sacred container that opens up our spiritual connection. I think that is the goal, and I think that's what inspires me now. And I'm just really excited to have this conversation. as we move forward today and hear what Elias has to say. But I think that's me. And this is a bit of a plug for our nonprofit that trains professionals in ketamine-assisted work with a sacred container. So I'll wrap up there, Rael, and hand it over to you and Elias.
Wonderful. Thanks so much for that. I really appreciate the focus on transformational medicine as the kind of context and container for viewing this. And it speaks to me partly because, that's in a way what has kept me from getting into outpatient psychiatry here in my academic role. I just couldn't bring myself to want to do that work. And so, my clinical work is in the psychiatric ER, where we just don't have many other options besides pharmacology. Western medicine seems to specialize and manage emergency situations especially well. And we could do a lot better, but at least there I didn't have to face this really deep inner conflict that, has just been a real challenge. How can I act in the world as a psychiatrist with that model that I just can't resonate with? So anyway, thank you for sharing. I'd like to introduce Elias Dakwar. Elias is an associate professor of clinical psychiatry at Columbia University Department of Psychiatry and researches novel treatments for addictions with the support of several grants from NIDA and NIAA. A special focus of his research has been evaluating subanesthetic ketamine infusions for cocaine use disorders in both laboratory and clinical settings, as well as investigating ketamine infusions as an adjunct to mindfulness-based treatment, motivational interviewing, and other behavioral frameworks for alcohol, cannabis, and opioid use disorders. He has a more general interest in the impact of non-ordinary experiences and of the interventions that might occasion them in psychiatric treatment. And I'll just say one of the things I'm especially honored to have you join us around, Elias, is, having really kept my pulse on the field of psychedelic assisted therapy, as well as meditation and mindfulness assisted therapies. I've been really just yearning to see these things combined, as I have a deep sense that they are so complementary, and to see your recent work over these last few years, not only combining them, but doing so with NIH dollars, really helped keep a light burning for me. So really looking forward to your presentation today, and thank you also for being here, Elias.
And thank you for inviting me, and it's great to be here with you, Rael, and with Scott. And looking forward to sharing some information and experience with ketamine and mindfulness I've had over the past 10 years or so. Let me just share my screen. So the topic will be hallucinogens more generally, including ketamine, and how they might be combined with mindfulness in addiction treatment specifically, but with, I think, some implications for psychiatric disorders more generally. Just starting with disclosures, been funded by NIAAA and NIDA, and I have no conflicts of interest to report. So I hope that, by the end of this talk, we'll have a better sense of the various ways that ketamine and other hallucinogens within a mindfulness-based framework might exert efficacy in addiction treatment settings. We'll begin by talking about what addiction is, how we attend to it, what the roles are for hallucinogenic psychedelic substances. I have a fairly expansive view of addiction. Contentment-driven, reactive, complacent, rigid, agitated decision-making on repeat, mostly the lives of us all. With addiction, I think it takes on a particularly salient cast. It can occur with nearly anything. Those substances, processes invested with meaning and value are most compelling. Brain-based models of addiction are inadequate, as are structuralist, economic, cultural models. And self-medication, whereby the person is getting intoxicated in order to palliate a particular mode of distress, isn't the entirety of it either. So there are several models of addiction treatment. There's harm reduction. There's a medical model, which is either abstinence-based or use reduction. And it can fall into several heuristics: biological, behavioral, existential, psychological, psychospiritual. And then there's the communal. I'm going to speak about how hallucinogens, psychedelics might fit into any of these. So starting with harm reduction, it's non-abstinence focused addiction care intended to develop a healthy relationship with substances and the harm surrounding them. So the intention isn't to stop using, it's to help people manage their use. And survey data suggests that recreational use of psychedelics dampens the harms associated with illicit substance use. People are less likely to become addicted, less likely to overdose if they also engage with psychedelics. But all of this evidence is anecdotal, including the occasional heroic doses where people will take a lot of mushrooms or LSD and have some kind of large experience that compels them to change their ways. Microdosing serotonergic hallucinogens may also be helpful, but again, it's anecdotal. So-called green recovery refers to using cannabis regularly in order to stave off the more deleterious effects of addiction. And sustained ketamine use has also been cited as a way for people to address addiction. What about the medical model? So ketamine is a good case study. We'll be talking about that most robustly. It has the most clinical experience and modern randomized clinical trial evidence justifying its use. Trials have been conducted or underway investigating ketamine for cocaine, alcohol, opioid, tobacco, and cannabis use disorders in a variety of contexts. We'll talk about those as well. But modern research is also being conducted, as everyone knows, investigating psilocybin, tobacco, alcohol, cocaine use disorder. There's some startups investigating MDMA, 5-methoxy-DMT, and ibogaine analogs for addiction. But these are far more preliminary. So let's begin by just going over the different models in which psychedelics, hallucinogens have been incorporated. And Scott went over some of them. So in the 50s and 60s, thousands of participants received hallucinogens safely and with potential therapeutic benefit under well-studied circumstances. And the two models that were investigated are the psycholytic, that roughly means mind dissolving. It was developed in Europe. And the intention there is to facilitate therapy, specifically psychodynamic therapy, but it's taken a more universal cast recently where it can facilitate other modes of therapy too. And in the initial iteration, the way that it would facilitate therapy is by softening defenses, allowing free association, transference fantasy, promoting introspection. So in effect, the agent is working in the service of the therapy. It's not central. Psychedelic models, the psychedelic means mind manifesting. That model really sees the experience as the center piece and is oriented around preparing for it, guiding people through it, and then subsequently working through and incorporating whatever insights, perspectival shifts might have happened during the experience. So it's a much more ambitious and so-called transformative paradigm. You know, a lot of critics of the psychedelic model, see it as quintessentially American, with a kind of vestigial religiosity to it, that people can be capable of sort of redemptive experience. So it's important to kind of pay attention to some of these nuances because they do influence the way we approach these substances, both in research and clinical settings. Either model is usually individual. but could be adapted to a group setting. And I agree with Scott that the group setting is a really important resource to consider, not only in terms of scalability and cost efficiency, but also in terms of efficacy. Psychoactive effects are important in all of these models. So it's not a neurobiological model with the psychoactive effects simply irrelevant or epiphenomenal, that they're crucial somehow to the medicines doing what they do. And as far as ketamine goes, these different models serve as the foundation for current frameworks which ketamine is given. Just a review of ketamine's psychoactive profile in relation to other substances. This is the 5D-ASC scale. It's commonly used to represent the psychoactive effects of substances. And we see here that ketamine basically follows a similar profile as psilocybin LSD, with perhaps more self-disintegration and less perceptual alterations. One caveat here is that ketamine was given in a biological model. It wasn't given in the psychedelic model that psilocybin, MDMA, and LSD were given in. And given that there wasn't the sort of set and setting, the preparation that usually accompanies that model, that may have impacted the psychoactive effects that emerged. This will be relevant later when I discuss some of the mystical type effects that I've seen with ketamine in our studies. So other models that have kind of emerged in this so-called renaissance of psychedelic research, ketamine facilitates learning and behavioral modification through the promotion of the neuroplastic window or critical period, allowing for behavior change. Ketamine disrupts neuroadaptations resulting from sustained substance exposure that perpetuate problematic use, improve functional connectivity, prediction coding, belief formation, reward science, glutamate-mediated excitotoxicity, neurodegenerative changes. And lastly, ketamine facilitates mindfulness training by providing access to contemplative experience, removing obstacles, motivating a practice. So at the time that these substances were researched initially, the 50s and 60s, though the counterculture was steeped in contemplative practices from the East. And while they were anecdotally being used in that way outside of the clinic, the academy was very much ensconced in the binary that I mentioned before, either psychedelic or psycholytic. I argue that the mindfulness-based framework is a confluence of the two, more modest than the transformative psychedelic model, but also much more focused on developing a particular perspective that the psycholytic model doesn't give as much attention to. So ketamine was very interesting to me because it's legal and incredibly accessible. And also, we're not as beset by some of the challenges that come with extracting indigenous traditions and commercializing them, secularizing them, medicalizing them. Seems to occasion very comparable effects. And for various reasons, I thought it would be a much better substance to study than any of the more exotic, but for the reasons I just mentioned, problematic substances. So I envisioned that ketamine would pave the way for a very different mode of psychiatric care, not so pharmacotherapy centered, not driven by big pharma, motivated towards psychotherapy-based treatments, bringing back engagement, bringing back experience, subjectivity to the clinic, and also doing so in a way that doesn't exclude certain people from treatment because of medication costs, et cetera, ketamine being as cheap as it is. We're seeing with the rash of for-profit ketamine clinics, a real problem with my thinking initially. I hadn't kind of considered the ways that ketamine might lend itself to yet another cash cow. But that's where my thinking was moving into this research initially. I was also quite interested in contemplative experience and meditation, and was motivated to find a way to facilitate meditation training, specifically for people who might have otherwise difficulty doing it because of addiction-related vulnerabilities or other psychiatric issues. So anyway, the first study that I did was a small early study investigating whether a single dose of ketamine improves 24 hours post-infusion motivation to stop, as well as reducing cue-induced craving. We found that it did so quite robustly. But of course, those measures of addiction don't really get to the heart of it. Addiction isn't simply, wanting to keep using or having low cue-induced craving. It's behavior. It's people acting despite their perhaps best intentions. So we also wanted to investigate whether choice was affected. A subsequent larger study found that people who received ketamine were less likely to smoke cocaine in a human laboratory about 24 hours later. The paradigm was basically giving them 5 choices of freebase cocaine. They could either choose to use or get a little bit of money instead, which would be given the following day when they leave the hospital. And what we found was that ketamine robustly decreased choice behavior in the human laboratory. We also, in this series of early trials, investigated psychoactive experiences. It's well known that ketamine results in dissociative experiences, and that it has some psychotomimetic effects. It's often used in drug models of psychosis to mimic negative symptoms of schizophrenia. It's one of the most robust drug models of psychosis for that reason. But its effect on mystical type experiences is unclear. And as I said, I was interested in how ketamine might facilitate meditative experience. And meditative experience is similarly characterized by so-called mystical type phenomena. So we looked at whether ketamine dose dependently increases various aspects of the mystical type experience. Unity, feeling of awe, new view of reality, a sense of sanctity or holiness, sense of things being alive, sense of peace or joyfulness, etc. And what we found was that ketamine dose dependently increased mystical type phenomena with a lower dose separating from placebo and a higher dose separating both from placebo and the lower dose. So that's considered a dose-dependent indication of its mystical type phenomena. So as I mentioned, I'm interested in mindfulness and meditation practice. Everyone knows, I imagine here, what mindfulness is. It's giving deliberate attention a certain way with acceptance, non-reactivity, moment-to-moment awareness. This, of course, is the secular definition that has come to us thanks to Jon Kabat-Zinn. And of course, Buddhism has a more expansive view of what mindfulness is. It pertains also to this process of gaining in wisdom, compassion, ultimately in the service of liberation, of oneself, and also engaging in the world in a way that facilitates the liberation of others. That isn't quite our focus in clinical settings, but we have looked at how this might be helpful as a domain, as a dimension to cultivate in the service of addressing various psychiatric disorders. I would argue that addiction is the exact antipode of mindfulness. It's anti-mindful. It's not being accepting, being reactive, being distracted, being very contentment-driven. So not really inhabiting the present, but instead having one's sights set on the future or on rekindling some past experience, and all within a deeply agitated state. You know, it's not a pleasant place to be, which is why people ultimately come in for help. And I did an early study investigating a mindfulness training regimen for addicted people. And while some people benefited, a lot of them reported a lot of difficulty. The same issues we were trying to address with mindfulness training really compromised their capacity to engage with the practice. And we had some very good people training them. It wasn't a matter of you know, therapist incompetence or something. That, you know, there's some real challenges when trying to open up this door for certain people. So I turned to these substances as a mode of helping people overcome these hurdles. And there are various ways it might do that. It might provide an experiential stepping stone, providing an immediate, intimate experience of what mindfulness is, of what contemplative experience is, providing a kind of example that would motivate a practice, may lead to an afterglow of enhanced mindfulness, or feel a little more open, calmer. May lead to changes in motivation as well. May create opportunity for reappraisal of values, where they find themselves just better able to understand why this might be helpful, why it's important to move beyond the addicted stance. I want to go over how the mindfulness framework actually looked practically in our trials. So we gave IV infusions in the hallucinogenic dose range. Participants were taught how to meditate prior to infusion. Intention setting was oriented around mindfulness-based commitments, being open, attentive, non-reactive, non-judgmental. This cultivation of equanimity and dispassion were also intended to disrupt attachment to and reification of the experience. You know, a lot of people celebrate the finding of in the psilocybin trial that Scott mentioned earlier. You know, this was the top 5 experience of my life. I'm wary of things like that. I think all experience should be given a certain care and respect and humility. And creating a kind of hierarchy of experiences is exactly where people with addiction can go wrong, trying to re-inhabit a certain state of being or attaching to it as if it represents the apotheosis of life. So we encourage them to pass through the experience as if it's the moment, and to practice engaging with the moment as it emerges without finding in it some kind of sacred gift or something from that is otherwise inaccessible. They engage in a body scan for 10 minutes while IMAS before a bolus dose is given and infusion is initiated. We don't have a playlist. It's a silent practice, and it's minimally guided. So we're not telling people to enter into some cosmic samadhi or, you know, be attuned with the Godhead or anything like that. It's, you know, just pay attention to your breath, stay with the present, allow the experience to unfold, etc. And then there's a debriefing afterwards. So in all of the studies that we did, including the laboratory studies I just mentioned, this was the way the infusion was framed. And one of our research assistants is modeling the ketamine pose here. So the first clinical trial looked at facilitating mindfulness-based relapse prevention with ketamine. So might ketamine promote fruitful engagement with a mindfulness-based behavioral modification platform? That was the question. It was a clinical trial examining a single ketamine infusion on cocaine-dependent individuals, initiating a 5-week regimen of mindfulness-based relapse prevention. Very briefly, the structure of the study was that ketamine was given while people were hospitalized for 5 days, during which they were abstinent, and during which they also received a lot of mindfulness training. So mindfulness-based relapse prevention usually takes place over the course of about 8 weeks, we crammed the first 4 weeks into that hospitalization. And this was intended to exploit the window of opportunity that might have been created by people first coming into the hospital, also receiving ketamine. There was no preparation in the way that psilocybin preparation might occur, where we're telling people, they might have this mind-blowing experience or whatever. It's, there's a medicine you'll be getting that is intended to help move things along. And mindfulness is really the crux of the regimen, like practicing it, returning to it, remaining attuned to the commitments inherent to it. So pretty significant findings in the final 2 weeks. These findings persisted for several months after. So this was sufficient to create the kind of long-lasting effects that we've been told only psilocybin or other serotonergic hallucinogens can do. So ketamine can also be very powerful if framed in a responsible, thoughtful manner within a clinical framework that can synergize with its effects. This shows days to first use or dropout. Ketamine delayed time to first use or dropout. Subsequent study examined on an outpatient basis a single ketamine infusion versus midazolam for alcohol use disorder. And this was also very much mindfulness based. We incorporated a more intense hold on one second. Yeah, excuse me, you're going to have to go down. Thank you. Okay, 4:15. Thanks. So, sorry about that. So this also incorporated a motivational enhancement program to prepare people for abstinence initiation. And then they ended up coming into a mindfulness-based framework after that. So the motivational enhancement piece was really intended to engage them and get them clear on what their goals are and to think more deeply about values and priorities, commitments. Again, this treatment both promoted abstinence and delayed the time to relapse. I want to just go over the psychoactive effects. I think they're important to mention and to kind of think about critically. So we looked in the laboratory study examining cocaine choice behavior, whether ketamine produced dissociative experiences, non-death experiences, and mystical type experiences. And we found that ketamine promoted all of those more than midazolam did. This final score is a global improvement score that kind of computed both the effect on choice behavior and also the impact in the natural ecology on craving and use. So ketamine had more improvement associated with it than midazolam. Then we looked at whether mystical type experiences, dissociative experiences, near-death experiences correlated with global improvement. They all did, but only mystical type experience mediated the effect of ketamine on global improvement. What that means is when you put everything into a model, whether they got ketamine, midazolam, the different psychoactive effects, only mystical type experience emerged as significant. Now that's a very powerful finding. That suggests that mystical type experience was even more important than whether they got ketamine or not. Mediation can mean many things. This means statistical mediation, that there's a very statistically significant relationship. It doesn't really give us any information about causality, et cetera, but it's a very compelling finding. And it speaks to what Scott was mentioning earlier, that these psychoactive effects are important and really important to attend to. So how do we summarize all of this? These mediation data suggest that engagement of consciousness in a certain way is crucial to efficacy in the addiction treatment setting. What I didn't mention, we did a similar analysis with the alcohol use disorder trial. We found that, yes, mystical type experience was the only psychoactive phenomena that mediated the effect. But the experience of ineffability in particular was most highly correlated with clinical improvement, which was somewhat surprising, but in light of all that's emerging now regarding the effect of these substances on belief formation, on kind of dissolving the top-down filtering process of the brain, disrupting discursive understanding, it kind of makes sense. They're basically plummeted into a sense of mystery, and with proper guidance, they reconstitute their understanding in a manner that is healthier and more adaptive. The usual modes of understanding, of reified thought and belief, are disruptive. It's also consistent with, as many of you know from your work with mindfulness. Mindfulness is ultimately about kind of recognizing the ultimate ambiguity and ephemerality of thought, that it's not really our surest guide to living life. That there's a deeper way of being that is more important to attend to. One can call it spirituality or consciousness or being, or however wants to conceptualize it. But there's a mode of being that transcends thought, transcends our usual categories of understanding. So anti-mindful, agitated, discursive, reactive, non-accepting, and attentive, basically addiction, is disrupted in the service of well-being. That's another way of interpreting these data. And this qualitative framing is consistent with both neuroimaging data with psychedelic meditation, default mode network attenuation, disruptive prediction coding, and with the Buddhist Vedantic Vipassana understanding of consciousness, where there's this agitated film over consciousness that kind of gets quieted and allows for deeper engagement with the way of things. And therapeutic frameworks that harness this interruption may be most impactful. I would argue that this has relevance to all hallucinogens, including the serotonergic variety, not just ketamine. So I mentioned earlier that there are communal frameworks for dealing with addiction. I think these are really important to attend to for the reasons Scott mentioned, which I alluded to earlier. Let's go over what is currently happening. So there are syncretic, neo-shamanic, quasi-religious groups working with, quote, plant medicines or, quote, entheogens in highly ritualized ceremonial contexts. Some are more organized, explicitly religious, such as Native American Church, UDV, Santo Daime. There's, of course, drug tourism and the so-called indigenous solution, people engaging with tribal medicine, expecting some kind of miraculous recovery. And the 12-step tradition is also a clearly marked path towards well-being and fellowship with religious overtones. And in fact, some groups are openly incorporating hallucinogens into their framework to deepen relationality, facilitate psychospiritual work. How do we synthesize all that? There's emerging interest among physicians, researchers, and group-based work informed by communal ceremonial hallucinogen use. Group work with ketamine, psilocybin. This offers greater affordability, access, scalability. Also, I would say the potential for new mechanisms. I'm not sure yet whether it's necessarily more effective, maybe for some people. There are opportunities for a type of work that is otherwise difficult in individual settings. Also, peer-to-peer support. I am deeply simpatico with what Scott said about equality, but maybe we should remove doctors from the situation altogether. Community-led efforts to train trip sitters, to have, especially with these becoming decriminalized and more accessible and not necessarily the province of psychiatrists, physicians, therapists alone, providing space for people to learn how to manage others. And decriminalization, legalization efforts also suggest more people might go it alone. So how do we prepare for that? Psychoeducation, with providing space for engaging in contemplative traditions or other practices that might allow for healthier engagement with these substances. Involving the cultural landscape more generally to promote greater care or responsibility. So in conclusion, the psychoactive effects of ketamine and other hallucinogens may be important to their efficacy in addiction treatment settings. This is really why these substances are a big deal, because what is often unmentioned is that for a long time, psychiatry has stigmatized experiences of this sort, and in fact, regarded them as aberrant, pathological. What this treatment model suggests, wait a minute, there's a place for these experiences in healing and well-being. And how do we occasion them? How do we make space for them? There are various models from medical to communal that might be helpful. Therapeutic frameworks mindful of psychoactive effects are crucial, and mindfulness training may be particularly relevant to addiction treatment, and perhaps this might be extended to group settings. Findings are preliminary, a lot of work ahead. So I appreciate everyone's attention. Sorry about the interruption. I have some patient issues to attend to shortly. But I hope this was enjoyable and instructive. And in gratitude, I couldn't have done this without the support of my institution, some really great collaborators, funding from NIH, and all the wonderful staff over the years and participants who have entrusted us with their suffering. Thank you.
Thank you, Elias. Very compelling narrative and findings. I know you have to run, so I do want to just see if you have time to answer 1 or 2 questions. If so, I can convey them to you quickly, or if you just have to run immediately, just let us know.
I may have to run immediately, but the guy will be coming shortly. If he comes, then I'll just give you guys a peace sign and peace out.
One of my old colleagues, psychiatrist and researcher at UCSD, is asking, could the effects have occurred in the absence of therapy mindfulness training, just from and this on the ketamine-assisted therapy data you present? He says it's unlikely, it seems unlikely to me, but good to know how you validated the importance of the adjunct.
Yeah, great question. I would say, well, yeah, of course, it makes intuitive sense. It's something that we're investigating more thoroughly right now. We have a 2x2 study going on with alcohol use disorder to investigate this specific question, whether therapy is important, beneficial.
Yeah.
Wrapping up, yeah. One other question?
Could you elaborate on the point about the psychedelic model being quintessentially American and the criticism attached?
Yeah, I couldn't help a little bit of provocation there. So this is actually something I'd heard from some European colleagues who were opining on, the rich tradition of religious movements and the kind of messianic type movements that have happened in American history. And, looked at through a certain lens, the psychedelic movement has shades of that, let's say, where there's this hope for some pivot that will change everything. And, we're in fact all wonderful creatures, and this world is wonderful, and it's just a matter of like letting the wonder in, and it's all good. And there may be truth to that, but one can see how that can lead people to criticism. I think from a purely clinical perspective, I think the transformative model is potentially deleterious, because not everyone is going to have the big Michael Pollan-esque experience that they read about, and it can be quite problematic for them to have that level of discouragement or disappointment. I think encouraging dispassion as occurs in the mindfulness framework, encouraging equanimity, making the most of whatever life presents us is a much more durable clinical model. So just speaking from a basic clinical perspective, I think we need to be careful about pumping people up for something that may not happen.
Yeah, it's clear. The same questioner for that question did also mention if you could just talk about a little how mindfulness-based frameworks perform in addiction care when done standalone without ketamine or
there was MBRP has been investigated for polysubstance use disorder, was found to be more effective than RPT at long-term remission rates. There's a new model called MORE that was developed to investigate mindfulness training for various pain conditions, among other things. And the aim there is to also focus on, I think, what the researchers call savoring, or learning how to really enjoy natural experience, attend to it. That's part of all mindfulness-based frameworks, but that's also been found helpful. So yeah, ketamine is not necessary. And in fact, what I should mention that in that Roots to Thrive study, ketamine basically performed equally to the other community-based therapies. Like the ketamine is helpful, but what's most important is relationality, is engagement with the work. So yeah, I think we should all remain kind of thoughtful about yeah, what practice means, what the spiritual path means. But with that, I have to run. Peace out.
All right.
I really enjoyed.
Thank you so much, Elias.
Hi, Elias.
Bye.
So Elias did warn us, but ahead of time, that this premature ending on his part would have to happen, just so everyone knows. But we do have a bit more time for a little more of a kind of community discussion. And one of our steering committee members from the Center for Mindfulness Science has just put in a comment that I think is a really good one to start off. Many of the medieval mystics, Julian of Norwich, Handwich, etc., had these type of experiences, affirming that in moving through the dark abyss, a spaciousness or ineffability in the chasm of love. Thank you for your sensitivity to the spiritual nuances of the contemplative traditions, with empathy for addictive behavior, brilliant yoking by both presenters. And I think, it's just a comment that I think is of relevance for us to consider, that certainly these kinds of experiences, and I think both Elias and you, Scott, really pointed to that it doesn't take a psychedelic substance to occasion them. Everything from the really most mundane of near-death experience to, spiritual practice related access.
And just wanting to build on Elias's parting comments is that the way I think about transformative process is that we hold out to people that it is possible. And we also hold out that it's possible that it won't look like much, and that really the power is in the work, the chop wood, carry water process that becomes the integration. And so the way I like to work is to hold out expectation that healing is possible. Healing can occur in marvelous, magnificent ways, or it can be subtle and easy to miss. And that one of my jobs as a practitioner is to help people see the ways in which they're healing, to help their morale. I love the Jerome Frank said the definition of psychotherapy is the restoration of morale. And in many ways, just a brilliant summation of it. And in our work, I think we have to be educators. We have to have ministerial zeal to inspire, and we have to comfort and hold. Also, be willing to help people see ways.
Yeah. One of the things that his, Elias is from Palestine, and I think, part of his perspective about it being a very American model is really born out of his legitimate life experience and perspectives and kind of cultural perspectives. I think, these Americans really get so excited about the possibility that the whole world can transform. And of course, that excitement can happen and does happen with people all over the world, but it brings to mind, a kind of moderating, sobering voice of my wife, who's from Iran, who grew up in the Iraq War, with bombs, American bombs falling on her town, and just how, as much as she does respect and hope that the psychedelic model of more transformative based psychotherapy and psychiatry can have a really powerful impact on the course of human history and suffering, it's so hard to really, believe it. And I think you pointed to that too, Scott, just saying, like, at the same time that this, reemergence of awareness and practice and, communal experience of these domains is being encouraged and even welcomed into the medical model, we are also what we seem to be on a collision course with dramatic, widespread suffering around the world. And so it's just a crux of the issue, I think, that we have to be attentive to and starting to embrace and look into the psychedelic model of care and therapy is, there's such a mystery here.
There is such a mystery, and helping people appreciate the mystery of it all and helping people get into wonder and awe, I think, is part of the spiritual process. Is that as we can respect the power that is greater than ourselves, we open ourselves up to, I think, a process of transformation. It's that surrender process that's so critical in the AA. And, probably my most common emphasis to people as they're entering the ketamine space is let go. I have to coach people to let go. Ketamine is good at showing people what that process is like.
Yeah. Along those lines, as a mindfulness teacher for many years, that is exactly the same instruction that I, find myself giving, especially to beginners as they're getting into practice, and I think those resonances between what it is to engage as a practitioner with mindfulness, training consciousness in the mind, the heart, and what it is for a facilitator of the psychedelic process to, provide some so-called external support to the inner journey that people are taken upon. It's just so interesting to me, and really is at the heart of why I find the confluence of the two to really hold promise, that there's so many resonances and similarities.
Yeah, and it's interesting that and I don't know the literature well enough to quote it, but there have been studies done with psychedelics that show that experienced meditators report that it helps them to deepen their practice. It doesn't take the place of meditation. And most people often go the path of Ram Dass, is that they start with psychedelics and end with meditation.
Yeah.
But,
Yeah.
Serious interface. Someone is asking us for you to tell us about the photograph on your back wall.
I just noticed that. That is me on my wedding day to my aforementioned wife, Dr. S. Al-Habibi, a music neuroscience researcher here at USC. And I'm in Ojai on what's called Meditation Mount, where there's that little post saying, may peace prevail on earth. And I think the other side of it is the Arabic version of those same words.
Peace pole. Well, that's a good signpost for our way today.
Indeed.
I think as we embrace the psychedelic space, we embrace a space of unity, connection, and love, and peace becomes our byword. Peace becomes our process. And I think it's one reason why this medicine calls so deeply to so many at this moment, because we're searching for peace, inner peace, communal peace, international peace, whatever.
Indeed. Yeah, I feel that as well. We only have a few more minutes, and a few additional questions have come in. I think the question that I think is on a number of people's minds is how are these psychedelics different from each other? You know, have you spoken about both of them? Both you and Elias did, and kind of highlighting some of the similarities despite very different mechanisms. But do you have any insights on maybe for some specific conditions and or purposes for inner growth and transformation, the ways in which, for example, MDMA, psilocybin, ketamine, and LSD may have really particular, stronger application?
Well, to my mind, I'm quite convinced that MDMA is far and away the best treatment for trauma, attachment issues, and probably even relational disturbances. I mean, I started my work with MDMA doing couples therapy, and it made me look like I was good at what I was doing. You know, I would say psilocybin, probably its best point is in the durability of its antidepressant effects. Psilocybin is not as easy to work with. It's got more rough edges. LSD is even more difficult to work with, more rough edges, but may have even a bit more power than psilocybin. But it's not to be trifled with. And I think there is more risk with it. Ketamine, I think of as a nimble small craft that can do everything sort of decently. It's legal, it's short acting, it's anxiolytic, it creates a neuroplastic window that's pretty reliable. It's without integration, it's not as durable. And so I think that's one of the downsides of ketamine, but it's probably easier to work with and certainly more compatible with office practice, and it is legal. So it's got that going for it. And maybe Colorado will be a different at the end of the day today, but you know, I think it's just so sad that we have to fight this battle about legality with these tools that are both safe and effective healing mechanisms. And you know, I'm really hopeful that we're in the aftermath of the drug war and looking to see what we can do to learn from that and learn from what our ancestors knew, and be open to what science tells us and not have this such a political process, which I think is unfortunate.
Wonderful parting comments, I think. Really a deep thank you to you, Scott. And for the community, I just want to make one additional kind of note here, which is that I and others in the Center for Mindfulness Science are actively now writing proposals combining mindfulness training and psychedelic therapy. And to the extent that, you know, the wider community wants to get involved in that here at USC, please feel free to be in touch. Certainly happy to work with you know, the community in the most collaborative way possible. And thank you again, Scott. I think what we're going to do is end the seminar now. And I want to also acknowledge the leadership, Dr. Jeffrey Gold and Not No with the Institute for Integrative Health for co-sponsoring this event with us. And we look forward to seeing participants at our next event in the series, the part 3 with psilocybin-assisted therapy in January.
My pleasure. Happy to be a part of this today, Rael.
Thank you.